we promise we have a special guest that is just fascinated. I'm gonna tell you something for sure. We're gonna stand in this one. It's the first time that in advance we're saying
I
that
don't
we're
believe you.
gonna in this one is gonna be amazing. So we have Dr. Robert Kerstein. He's been. I'm gonna let you talk in a little bit. Let me just say what I think about what you do because it's fantastic. It's incredible to know that 35 years ago, people was trying to see what the future was and trying to put all his life and his mentality, his expertise, his practicing and everything to try to develop a project that we today, we have an amazing device. But 35 years ago was a lot of hard times were this process. So Dr. Kirsten has been doing research and start with the first version of this scan. And for 35 years, he's been talking about it, demonstrating the neurological impact and describing techniques about the time of this occlusion and really important concept that has been inspired many people like Ben, that you guys had the chance to see his lecture. And this is just magnificent. So it's a total honor for us to have Robert here. I have the pleasure to meet him in Madrid like 5 years ago in a TMJ conference, and I always was amazed about how he can implement the technology because the technology by itself do nothing. Definitely in life is not easy or simple. You can try to be simple but not simplistic. If you want to get to this level of comprehension of data instrumentation, in data understanding, it's time, it's books to read, it's information to look. So here we have Robert, and well, honestly, Robert, I hope you have a good lunch and energy and you took a nap because we're going to squeeze you as hard as we can to get all the information. Welcome.
Well, thank you for having me. I'm honored to participate with all the fine speakers. So I appreciate the opportunity.
Fantastic.
Yes, I mean.
So yeah, we were talking earlier with Dr. Kerstein, Robert, if I may. So we're both from Boston, and actually, so that was another great point for me. But I was telling him that I remembered when I was in school between 90 and 92, the last 2 years in the clinic, that there was this graduate student that would come in with this machine as we were working. It was politely asked, "Hey, do you mind if I take a scan of your patient?" And all of us were like looking at him like he had two heads. We had no idea what he's doing, putting this sensor in people's mouth and getting a bite. And it was the very beginning. Probably at some point he was doing something for Dr. Kerstein or collecting some data for him. But yeah, since then I really have not had any personal contact and knowledge of what this does. I know in general what it was supposed to be doing, but I really had no idea about the details that Dr. Kerstein, in terms of the neurophysiology of the bite, has figured out and has developed so much on. And I'm eager to learn as much as I can. So, without any further ado, Dr. Kerstein, go ahead.
Well, what would you like to ask me?
No, first we want that you say all your fans welcome, and then we start shooting questions.
Well, thank you for having me, as I said, and I'm happy to be here, participate with you guys. It's quite a group of...
One thing that is, Dr. Kerstein, tell us, how did you even started thinking about this? How did you come up with this idea of I mean, measurement is not a new idea, but how did you come up with it?
It wasn't my idea to measure the occlusion. It was actually a number of faculty people at BU and at Tufts who invested in developing the first T-scan. It was spearheaded by an engineer from MIT and my professor at Tufts, Dr. William Mannis. And but there was a group at BU that was involved, and at Tufts, and they developed the first computer technology for dentistry. It superseded all technologies. It came before CEREC. Or right around the time of the first CEREC. And it had the capability to measure time and force, and not absolute force, not like pounds per square inch, but where there was too much in the arch, where there was too little in the arch, and also timing. And timing became the most important variable that you could manipulate. Force you could manipulate, but when you adjusted for high force, all you did was move the force from one tooth to another. But when you adjusted timing and shortened timing differences between teeth, you got much better responses from the T-scan data, and you also got much better responses from the patient. I remember one night we used to work, graduate students don't have to spend money to go to school. It costs thousands of dollars to be a prosthodontic resident. And so we would work at night in the clinic, and we would call it drilling for dollars. Like there was a movie, afternoon day show, selling for dollars. We used to call it drilling for dollars. So we would have friends come in and we'd make crowns or we'd do fillings. And I treated some people with T-scan that I adjusted their bites, shortening the time of disclusion, which was a discovery with the T-scan one. It was the first thing that was actually discovered, but you could measure someone making an excursion. You can see how long their back teeth rubbed together, and then you could remove some of the tooth structure and the timing of disclusion would go down. And these people would say, wow, my face doesn't hurt anymore, or my headaches went away ever since you fixed my bite. And it wasn't that I was specifically treating dysfunction, but they responded in a way that it was improving dysfunction they had. And
Robert, let me stop with you 1 second, just 1 second, because let's start explain what is the disocclusion timing. And let me see if this analogy it fits the definition. Sometimes we have these patients that you try to ask them to slide to one side, and it's some patients that they can don't even think to do it, and even in some point the mandible start shaking, and they cannot overpass that point, and then you look, and no matter what it is, and eventually the only way that you can make that patient to pass that is like a neurological barrier is you need to scratch them or say follow my finger, and they kind of start following because has something that guide them to that we can describe like the time. I mean, this is a major case, but something like the people know.
That would be an example of long disclusion. Long disclusion causes spasms, and we treat that. It's actually fascinating. In the appointments, when we fix the disclusion time, the spasm is there at the beginning of the appointment, and within a few adjustments, the spasm goes away. So the disclusion time, by definition, is the time it takes to leave MIP completely intercuspated firmly, not maximum, but firmly, and slide out to the tip of your anterior teeth. It doesn't have to be the canine. It can be a lateral, it can be a central. You can use all the anterior teeth because they're neurologically different than the posterior teeth. And so when you reach that point where all the back teeth disengage, you have a timing element that left from a standard start, a physically stopped place, to a point where only the front teeth engage. And the duration of that is equal to the duration that the molar pulps and PDLs are compressed and flexed, and that incites muscle activity during that time frame. And the longer the disclusion time is, the worse is the muscle firing. So by manipulating the timing to short, where the person can move left as you were pointing, and they can do it, by refining their occlusion with the principles of disclusion time reduction, which is a whole science as to how to adjust the bite. It's not equilibrating. There's nothing to do with equilibrating, which is unmeasured, and it doesn't really have the science behind it to be a procedure that treats dysfunction. But disclusion time, you can shorten the time, and the muscle activity goes away right away. It goes away in the visit. And the person moves, and they don't have spasm anymore. And they can tell that, and you can tell that. And it happens right in the visit. So it shows you the impact of treating the neurology. What you're really treating is you're removing the surface engagement of the teeth so that the neurology doesn't get flexed and compressed. And once that stops, the muscle activity stops being fired. And then the system calms down. And so you can treat really in MIP many people. And if you can't treat them in MIP, like if they don't have front tooth contact, you can do ortho beforehand and move their front teeth into contact and then treat them in MIP. And then you don't have to crown teeth or move the mandible. So it's a really powerful mechanism. And it has to do with the neurophysiology of the periodontal ligaments and the pulps, which is, as I said, not that well understood in dentistry.
Now, when you get to this idea to start developing this, you were already knowledgeable about superficial muscle electromyographies, or at the beginning you were just thinking in teeth and thinking in the disocclusion and just figuring that the muscles has a component in there? Or at that time that you start trying to figure this out, you already have the support for EMGs to confirm your thinking process, or was an independent thinking process? I'm just trying to see if everything is and then.
It's a very good question, Javier. So at the time that I was doing this early on, when I discovered the disclusion time in the late 1980s, and people were getting better when I would fix their disclusion time, I started writing about it. And then I did a study with EMG that was at the Tufts Gelb Center, the TMJ Center, where I worked with an EMG technician there. And we found this validation that the muscle activity levels went way down by shortening the disclusion time. And that was the start of it. And then in the early 2000s, the T-scan EMG was built. And that was an idea that combined companies BioResearch and TechScan, their two technologies, to make the first movie form of an EMG. So the EMG actually plays like a T-scan movie, which is atypical because most EMGs are static pictures of lots of waves and they don't play like a movie. This is a video of muscle firing that cycles along with the teeth. It's amazing. Well, so the two technologies together, now you could see that the moment you did this, the change in the physiology. And the way we measure an effect, the physiologic effect, is we take this data beforehand, the day of treatment, always, even if we've had another visit beforehand where we've taken the data to verify that the disclusion time is a factor. And and then the same day we take the data, we treat the patient, we take the data again, and we see marked changes in the amount of muscle activity that's being made. And of course, the patient is able to move without spasming, for example, or the patients will say, I came in with 2 bites, but now I only have 1 bite. And again, this is not through mandibular advancement or repositioning. It's not positional. It's all done in MIP, which is so patient-friendly because you don't have to do all this dentistry or do ortho or move the mandible. Let's just generalize that. And the therapeutic effect is much greater than can be accomplished with a splint, because the splint doesn't fix the neurology. It just buffers the neurology. And so that's why they're therapeutic. And of course, you can make a splint and use the T-scan to put it in and optimize that so it's really high-level neurologically designed, but it still doesn't fix the neurology of the teeth, because when the person doesn't wear the splint, the orthotic, the teeth come back together, the neurology fires up again. And that's why it's hard to succeed with splint therapy, where disclusion time reduction is a self-limiting, very effective long-term treatment. Again, we have studies that show these things, and many through the literature. So the nature of it is it's really patient-friendly, and it's all due to the neurology.
Did you measure, of course, the neurology of teeth? And then can you say that when we put these layers, because you mentioned something about that the splint is a buffer effect, yes, it's an appliance to treat. But in some point, we're going to transition that patient on a solid occlusion. Can you tell that these layers that we put in, that we call in crowns, veneers, onlays, occlusal tops, whatever devices or restorative phases that we want to use to reestablish occlusion, can you tell that these layers reduce the neurological effects in some way?
It's a good question. I haven't studied it. It's actually a very good question. Does crowning of teeth reduce the neurology? I would say to you, from being a prosthodontist and from treating chronic pain and researching chronic pain, I would say no. I would say that the crowns worsen the neurology, and they tick up the teeth to be more of a problem, especially, well, the periodontal ligaments. Obviously, if the occlusion is overly forceful in any one area, or the occlusion sets up long disclusion in any one area, the periodontal ligaments, they don't know there's crowns up there. They don't really care about that. They're being pushed around and they just respond. And they fire off this noxious information that then travels into the brain and then leaves. And that's why the impact of the teeth is so powerful, is where the fibers go in the brain. But the pulp is different. The pulp is worsened by drilling the teeth and by sticking chemicals on the teeth and by cutting the tooth structure because of substance P, which is a simplistic toxin. As you know, there are many toxins, but just that alone. And then, of course, we cement the crowns on, we etch the dentin, we do all kinds of things that we try to make sure the crowns stay. And those chemicals do not favor pulpal response. So the beauty of the T-scan at delivery of a prosthodontic reconstruction is exactly that. You can fine-tune the neurology as best you can, despite the trauma to the pulps and despite the PDL responding regardless of what you put on the teeth. So there's a huge advantage to doing prosthodontic inserts with the T-scan. I spent my life doing that. I have lectures on implants. I have lectures on crown and bridge, on aesthetic dentistry. the neurology is at work no matter what we put on the teeth. And
Yeah, because this question that I asked you has like two implications. One is about layers, like because I think it's like you put a jacket on. You put a jacket on, you're gonna have this influence or whatever, right? So it's a resistant layer in one way, but also in the other way that I'm seeing is more about fulcruning and tension into the PDL by forces because we violating. No, let's say compensating because yes, it's not normal, but it's a compensation that patients can have the teeth to different levels and in some point you're going to make a restorative treatment and you're going to try to equalize or balance an occlusal plane.
yes,
And we
yes.
will make different ratios crowns, and then I'm assuming that you have a crown that is taller. In some point, you're going to have a bigger area of fulcrum. Is that interesting? Or it makes sense that the thinking that if I have a crown, that periodontal ligament need to be carrying if the force has like a bigger, how is that called when you're gonna make a fulcrum, la palanca. Yeah, it's
Lever.
like a
Lever?
lever. Yeah, exactly.
Yes.
That's the word. So
Yeah.
then in a taller crown, that's what I think it will do. So I think the neurology of the ligament can be more sensitive, and that goes to the cases. So how you can relate this transition into the forces because you have cases that are specifically being studied this with implants and cases combination because I
Yes.
think this can be the toughest case. So what you can tell us about this neurology of the PDF in these variations, anatomic variations, or these combination cases with implants?
Well, first, to address the fulcrum issue, certainly a taller crown single unit would have a larger fulcrum if it was out of the bone. You know, there was less bone around it. That would be the reason it would be, let's say, a taller crown than one on the other side of the arch, which had normal bone. And that would definitely have a larger lever system, having less bone. But the mechanical action of compressing that is what matters, not the lever arm. So if you have short disclusion time, you may not flex that tooth at all. It still can have a nice solid closure stop, and that closure stop will compress the PDL. But as I said, closing is not what people do. They move around to chew, eat, function, swallow, clench, and grind. They're always moving around. So excursive movements are much more important. So the lever arm only is a factor if there's a lateral stress on the tooth and it pushes the tooth wider. You know, it shoves it wider to the buccal or wider to the lingual. It doesn't change the fact that the mechanoreceptor is still being compressed. And so neurologically, there's no difference. Anatomically, there's a difference. There's less fibers because there's less bone support and less gum tissue, but not necessarily mechanically. And of course, that doesn't affect the pulp. The length of the crown has no bearing on flexing and the pulp responding. So those two elements together are what make all this muscle activity that leads to so many problems that we see on a regular basis. And the T-scan EMG can really treat that, really treat it. That's the beauty of it, having the muscle and the teeth together.
What can be the limitation of, I mean, for us that we've been using EMGs for a long time, we have a scan 11 that is a scan that can technically can tell us how is the occlusion based in muscle, the superficial muscle, and kind of give us an idea what can be the contact points. We already asked this to everybody and pretty much everybody in the same arena. It's a good tool, but it's not a totally fine tuning as T-scan. How you find or how you've been using this mesh, this relation between superficial EMGs and T-scan?
Well, we use it to measure physiology. We can tell the closure physiology, we can tell the intercuspation physiology, and we can tell the excursive physiology. So you can study all three parts of it. And the value of the EMG is not to tell you the occlusion is good or not. That's a misnomer. There's no way to read EMG waves and determine that, yes, the bite is balanced, or no, the bite isn't balanced. Having synergy and symmetry amongst the muscles is a beneficial physiologic state, but it doesn't guarantee occlusal balance. Occlusal balance is about occlusion and the pressures of the interface between the teeth, and you can only measure that with the T-scan. Carbon paper doesn't measure it, wax doesn't measure it, chew cycles don't measure it. You got to measure it with the T-scan sensor that measures pressure, force, and time, and then you can optimize that. So like the idea of putting the contacts in the right places is theoretically correct, but it doesn't account for pressure, force, and timing. It just accounts for landing, right? And how the teeth land, not on the quality of the landing. And so the T-scan is where you determine the balance and the timing, the disclusion, the equality right to left, the anterior posterior division of forces, and which teeth take control over the guidance and when. The EMG is the mirror of your success. It shows you, yes, you optimized the occlusion because you see symmetry and synergy improve from pre-treatment to post-treatment enclosure. And then you see excursive muscle activity, which is the main problem. Excursive muscle firing is the main problem that is at the core of many dental problems that dentists see routinely and face difficulty with. TMD symptoms, excursive friction is a main player in that. Sleep, bruxism, excursive friction is a main player in that. And so you see in the EMG after you treat someone, that stuff, that excursive hyperactivity is removed. So you can tell both sides, the closure side with the synergy and symmetry improvements, and the excursive side, which is where the function occurs. And so the two programs together are state of the art. Without the T-scan, the EMG is very difficult to interpret. And although there are principles of interpreting it, they're not applicable to fractions of seconds of tooth contact. There's no way to look at a pattern of waves and say, yeah, that's the mesial of premolar, the premolar that strikes at 0.8 seconds into the closure sequence. You can't know that, right? But with the T-scan, you can know when that premolar strikes, when the molar strikes, when the canine strikes, what pressure's on them, how long they strike for, how much time they are involved in an excursion, how much overload is an implant. All those things are very visible with the T-scan, and you can't see any of that in the EMG. So with respect to the neurology and the implants, so there's a couple of interesting things the EMG shows with the implants. When you have a full implant case, if there's friction and lack of disclusion posteriorly, although there is no periodontal ligament, there is resistive friction. Resistive friction is surfaces that don't slide freely over each other, like what you would show me, what you're asking about, Javier, with the spasm the patient was having. They're having resistive friction. Their teeth are in the way and they can't get past them, and that's weakening their muscles. That's the direct neural connection. But in implants, you don't have a direct neural connection. You have a bone fusing, and the teeth then stop the mandible from sliding freely if there's posterior interferences, and you still get a neural response. You get a resistive muscle struggle that raises muscle activity. So free disclusion on implants ensures less of that resistive excess muscle firing. And there's also a beautiful way to use the full arch implant case is not to have the canine be the guiding tooth. It's to have the guiding teeth be the centrals and the laterals, because the base of the horseshoe is always more resistive than the corners of the horseshoe. In other words, the torquing capability of going out to the side. When I go out to the side at an angle in an implant case, I pull the whole case that way. It has to go that way. And so instead of using the canine, I would use the centrals and laterals, and I would use the base of the, I don't know if you can see it in my hand, you can't really see it, the base of the arch, like the Romans would build on the Colosseum. They stacked levels on the base of the arch. That's the same principle you can use with the implant cases, and your disclusion will be less forceful and more preservational than if you use the canine in the premolar area, because the torquing is greatly reduced. There's a lot.
So let's talk about a little bit about the centric stoppers in that comparison about natural dentition simultaneously with implants. I mean,
Well,
we
with the
always
T-scan,
talk that we have to leave the implant is like for contact, so when the patient clench, it's like a more equal. What is your scientific thinking or way to do it, because you measure it?
well, we use the timing again. Again, the T-scan, the timing capability, it records in 0.003 of a second. So you can know exactly what order things strike in. So what we do is we have the teeth near the implant strike first, and the implant strikes afterwards with lower force. And we do that through corrective adjusting, and we make a time delay. And so the teeth are not out of contact or kept low, let's say. They're in contact, but they're late in the sequence, and they're late. And when things rise late, which is very interesting, if you have a T-scan, you can see this very readily, the things that rise earliest become the most forceful. So if they get in the way first and then the mandible compresses more and more to get more teeth together, the early contacts rise to be more forceful than the later ones. So
let me interrupt you there. I'm sorry. are you delaying the timing by opening the slopes of the crowns so the distance of the engagement it will make that they will activate later?
It's really the closure contacts, the stops are delayed so that the teeth land.
Okay.
And then we try to, it's actually fascinating. You can actually track the implant loading order and the tooth contact loading order, tooth by tooth, if you want, with the T-scan. You can look at the neighboring tooth only and the implant next to it, and that's all you have as data. And that's how precise it is. So what we do is the closure stops come together late in the sequence, and that keeps them low force. And then we also use, in excursions, we exclude the implants. And if there's a canine implant, everybody has always asked, well, if there's a canine implant, what do? We use the lateral in front of it. And laterals are great teeth when there's no posterior teeth involved because you have very low muscle firing. And so the principle of exclusion applies to the natural teeth as well. And to the implants as well. You don't want the lateral friction from the shear standpoint. You don't want the lateral friction on the implants from the resistive muscle firing standpoint. You want the exclusion to be free, but the loading order, and this is really the beauty of using the T-scan, the timing feature. Let's say you had 3 implants on the upper left, right? That's, 30% of the patient's arch against the rest of its natural teeth, right? So if we take that out of contact, those 3 teeth or 4 teeth that are made there, that means the rest of the arch has to absorb all that stress. So what we do is we keep it in contact, but we delay it so it's loaded with less pressure. And then it supports the rest of the dentition. And then in the excursion, it excludes. The taking out of contact, say keeping a case low, works really well for a single unit. Like a premolar implant between 2 teeth is, if it's out of contact, well, it's not an issue. But 3 molars in a row or 2 molars and 2 molars, you can't take that out of occlusion. You totally move the forces to the other side of the arch. And when you see that on the T-scan, you see the center of force goes way off to one side, and the case is not in contact. So the time delay is a beautiful, sophisticated use of the T-scan. Any dentist can do it. You just have to know how to use a T-scan.
This is fascinating. How do you like it, Hamid?
Phenomenal. It's incredible. Just by delaying it, you mean that you're not going to take them completely out of occlusion, but you're going to lower them and lighten the contact on them. So am I understanding this correctly?
Yes, the effect is that. So what you're doing is you are grazing the surface of the implant crowns and the teeth to adjust them so the order of reaching 50–60% of total force, the natural teeth does it first. You can see the forces rising in the T-scan. It's a very nice graphical, easy to follow bar graph that goes up. So as they go up on the teeth nearby, then you bring the implants up afterwards. So they come up with low forces automatically if they're delayed, and they load after about the tooth in front of them makes it halfway into its full loading sequence. And again, this is what you can see. And all of this is occurring in 0.2 of a second, 1/10 of a second, 0.3 of a second. Things that you cannot tell with your eye if it's just,
God. Wow.
the exclusion time is the same.
Certainly, just putting paper in there is impossible to know because you're probably just going to get red everywhere or blue everywhere. And there's no way to really scientifically say, okay, that the strength is more here, we guess.
Where it starts the contraction, because at the end, when you squeeze, yeah, it's going to be equal. But what microfraction hits first? That's what is this beauty.
Yes, exactly. And with the paper, with the T-scan, you need the paper. The T-scan sensor is a flexible printed circuit. It doesn't mark the teeth, but using high quality paper, thin paper essentially, is really helpful. And not putting Vaseline on it is really helpful because you get no flaws or minimal flaws. And the thicker you go, the worse the flaws are. So by using thinner paper with the T-scan, you can optimize any contact pattern really well in ways you can't do without it. And it's exactly right. What you said about not knowing which one is more, you can't tell. Studies are very clear. The carbon paper doesn't measure any force. The size doesn't explain force. The numbers of marks on the teeth doesn't show simultaneity in any way. It doesn't mean all the teeth are hitting at the same time. Not at all. And so these principles, when they're used to adjust teeth, can't be neurology. That's why the T-scan is so powerful. It controls the neurology of the patient, and that's where
you brought this up.
Come from.
Can you I know it's probably a very deep subject and everything. Can you give us a quick understanding of the neurophysiology of what you're fixing? What is
Yes.
happening?
Yes. Okay. So first, to understand the neurophysiology, you need to understand the neuroanatomy. And this really goes to the reach of how powerful the teeth are. And I'm just going to preface this before I explain it by saying that I find it fascinating that dentistry discounts the role the teeth have in many things as being causative, that we have shown in studies many, many times over. The teeth are absolutely the cause. They are the cause. These are things like cold sensitive teeth. They're not caused by roots being exposed, having dentin exposed. It's caused by occlusal trauma. It goes away right away once the disclusion time is fixed. We have studies on that. Sleep bruxism. Sleep bruxism is a tooth problem. It's not a central nervous system problem. It is because the teeth are part of the central nervous system, not because it comes from the central nervous system. There's some idea that it's trying to open the mandible for the airway to get blood to flow to the heart better in an apnea patient. That's totally unfounded. And then sleep bruxism also, when you treat the disclusion time, you also get opening of the airway automatically without needing an appliance. So I want you to understand there are things that we treat that many fields have said the teeth have nothing to do with. Now, once you understand the neurology, you'll realize why the teeth have so much to do with it. So here's the basic neurology. The posterior pulps and PDL fibers are the only peripheral nerve system in the entire human body. They are a peripheral nerve system that synapses inside the brain. All other peripheral nerves stop outside the brain. They synapse in ganglia before they enter the spinal column. They synapse, some of them synapse in ganglia on your neck. But the teeth, the molar PDLs and pulps, travel directly into the brain. They travel through the mesencephalic nucleus, and then they split there bilaterally to go to the trigeminal motor nucleus, the right and left trigeminal motor nucleus. There's also a set of fibers that splits from the mesencephalic nucleus and goes to the reticular formation of the brain. The reticular formation of the brain is this huge brain center that controls sleep and balance and posture and respiration and some sexual function and digestion and all these things, swallowing, okay? It's a diffuse, like 50% of your brain is in the reticular formation. So now you have these fibers, they go to into the center of the brain, so keep that in mind. They also go to these trigeminal motor nucleuses. And what they do there is they first synapse with the muscles of mastication and then muscles that involve swallowing, the mylohyoid, the digastrics, and the tensor veli palatini, which is a soft palate muscle. And they also synapse with the tympanic, tensor tympani, which is the muscle that covers your eardrum and opens your eardrum so you can hear sounds. So when you bite down, you automatically contract all those muscles. When you grind your teeth, you automatically contract all those muscles. You can't stop it. It's a one switch mechanism. Now, the fascinating thing about the reticular formation is that is why people see improvements in posture after they have their disclusion time changed. Like Ben he does posture analysis, and he takes pre and post treatment posture images with the graphs and the lines and the horizontals. He doesn't do any posture treatment. He treats the disclusion time, and a week later, the person's posture is almost fixed because the brain is no longer getting excess noxious output from the teeth in the same way. So there's huge reaching effects from the teeth to the center of the brain. And then from there, this noxious stimulus can attack a lot of things. Now, getting back to the main area, and this is the reason that we are so successful is when we treat the teeth, shorten the disclusion time, we control the volume of output to the trigeminal motor nucleus. So we reduce all these contractions instantaneously because the contractions come from the pulp flexing and the tooth being pushed into the PDL, and it stops. Once you stop flexing the teeth, it stops. Now, when the person bites down, they still make muscle activity. When the person chews, they still make muscle activity, but the volume is so much less because the teeth themselves aren't adding on to the problem that's neurologic. And why is it we have this mechanism that builds up muscle activity and tires out our jaw and we can't chew and we get spasms? It's to swallow. When you bite down, you swallow. Everything happens in mediating swallowing. So the airway closes, not the airway, but the pharynx closes, and the teeth hold the mandible strong, the tongue moves back, the ears open, right? All those things are swallowing. And so the swallow mechanism is what's really affected by it. And the beauty of the DTR process is it relaxes the entire swallow mechanism. And and it affects many things. So it affects sleep. For example, sleep bruxism, that's one of the areas that people say the teeth have nothing to do with it, that they're an end product of the brain making people grind their teeth. No, we've been treating bruxism since 1995. We have studies that show we can stop bruxism without a splint by treating the dissolution time. And now with CT, we're seeing the airways open. We never took CTs, but in the last 5-7 years, people started taking CT routinely for implant therapy and planning, surgeries. And we see airways opening with DTR, no treatment rendered to the palate, no to the throat. And of course, I've heard these things from patients for years. Now we're really seeing things I've heard for years. People would come back after their dissolution time was fixed and they would say, I'm really sleeping a lot better. My husband doesn't hear me grinding my teeth. He used to make me leave the room. I don't do it anymore. He doesn't wake me up anymore. And I'm sleeping deeper and I don't seem as tired. And so then we started seeing on CTs, wow, look, the airway gained 2 millimeters in 3 places. The airway is no longer as constricted. And people would come into the office and say things like, before you treated my bite, my neck was always straight. I would feel like someone on my throat, and now it's gone. And so the reach of the neurology is staggering, and it's not understood at all. And so the T-scan allows you to fine-tune the neurology. The T-scan EMG together, they allow you to fine-tune the neurology like a finely honed machine, like a Swiss watch, as best you can make it. And that has to do with using it well, and the principles of treating the occlusion with it are very well defined. As I said, we have many studies and many papers for years now treating a lot of these things. And
so now let's go one level up, and I'm gonna come back to the question that I tell you before we start. T-scan doesn't know where the joints are. T-scan measuring the forces. Can you consider that can be a false positive by adjustment, because let's say the operator didn't realize that that patient has the disc not in place, and then let's say that they do the equilibration. Of course, it's gonna be part of the neurological input is gonna be corrected. It's gonna be clean, but it's structurally the structures are not aligned properly. So it's still for you important to the position of the condyles, the position of the TMJs, and the biodynamics working properly, right?
Yes, well, first, it's a very good question, Javier. Not everyone is a candidate for dissolution time reduction. Many are, and many patients that are being treated worldwide with other methods would absolutely quickly benefit from having their dissolution time fixed, like many. But the ones that aren't have structural deformities in their joints that don't allow the bite to be safely adjusted. So that would be, we've also studied that. We found that we can improve joint health by 2 Piper classifications using DTR. So if you're a Piper 3 and you go through DTR, you'll probably end up being a Piper 1, which is a major improvement without any therapy. Again, the reach of the neurology, relaxing the lateral pterygoid, relaxing the tension it has on the disc, allowing the disc to self-heal. So what we do to determine candidacy is we use CT, we use MRI, we use joint vibration analysis. We make sure that the joints are, condyles are corticated. We make sure there's disc space between the condyle and the glenoid fossa. We make sure that the skull base is intact. There's no holes in the condyle. There's no cysts. There's no effusions of fluid in the joint space. And of course, range of motion plays a role in that. How much someone can open, often will predict that someone has reasonably stable joints. But we always do a complete diagnosis, which involves a joint assessment, which would be MRI, at least CT and JVA, and then joint vibration analysis, which is a really helpful tool because, again, patient-friendly, doesn't cost a lot, easy to do, shows you that there's something wrong with a high degree of specificity, which is a really good thing. And then if you have something that's not so good on JVA, then you can do a CT or order an MRI and get a full picture, and then you can determine candidacy. So DTR is really applicable to the patient who has mild joint dysfunction, clicking and popping, disc displacement with reduction. I would say is absolutely a very safe person to treat. And once you get beyond displaced disc with reduction, if there's no disc space, if the condyl's up against the skull base, if there's no cortication or a zone of lack of cortication, then it's not a bite adjustment case. That's a case that you would then open the bite and establish space for the condyle to not be sanded away against the skull. And then you might do that with an appliance, or you might do that with a set of prosthetic temporaries if the patient has a worn dentition and you're going to restore them anyways. And when you do that step where you open them, reposition them, use the T-scan. So use the T-scan to finish the new splint that opens their bite to the new position, the orthotic. It's a great.
So then I come back to the initial question that I did. I say, so let's say that you have a patient for T-scan, you made a coronoplasty, you have all the numbers that you want, the occlusion time is as effective as you possibly can. And now technically all the nociception is removed, so patient technically can be okay. But let's say that that patient also, the mandibular trajectory is not correct. Let's say that for the physicians that we treat by arch of closure, let's say that that bite doesn't feel the conditions of what we look at. That's what these meetings is about. How many things we have in common, even that we do different things, right? So then we determine about, so you can actually, you can balance the occlusion into this patient in maximum intercuspation with the numbers that you want, and eventually we just provide the patient with a new bite, a new trajectory, let's say in an spleen, of course, because it's like a differential diagnostic. Can you bring that patient in that spleen to the same level of a neurological improvement, even that is in a totally different arch closure, let's say, to keep a standard?
Well, I can only answer by conjecture because I never really did that, and myself to be able to answer it. But
so it looks like we're gonna do like 3 research together. That sounds cool.
I'm always open to doing research with anyone who's interested in studying something. So as you can, if you look at my papers, there's all different names of people that have participated. So I'm happy to collaborate with you if you want to do a splint repositioning study with the T-scan or the T-scan EMG. Absolutely. But I would tell you that you can take that new scenario and make it as optimal as it can be. And that's the best you can do for the person, and they will get the most healing out of that situation. I think that's really so the splint is not a neurologic entity. It does buffer the neurology, but the occlusion against the splint will impact the neurology. And so if the splint is 75 left, 25 right, 75% force left, 25% right, one joint is getting way overloaded. One set of teeth is getting way overloaded. The physiologic balance is certainly not there, right? So those are the kinds of things that it doesn't sound like, people don't realize how far off a dental prosthesis can be, because it comes back from the lab and it sits on the articulator, and then you go and put it in the mouth and you grind it in so everything touches. The quality of everything touching is what is at play with the physiology and the neurophysiology. So the fact that things touch isn't good enough. That picture at the end of the lecture, everybody shows, let's say they're doing an aesthetic case and they show, see, here's the ugly smile beforehand, and then they show the brand new 28 units and it looks gorgeous. No one's putting a sensor in there between the teeth to see if it's 75 left, 25 right. How much is good is the canine guidance? How much disclusion is there? Is there balance? Is there simultaneity? No, it's all perceived to be there visually. And so when you do what you asked, if you take the T-scan to it, Javier, you'll make the best solution you can for that patient if you optimize that prosthesis. A splint, a crown and bridge case, an implant case, a denture, an overdenture, any scenario, you can optimize the patient adaptation because of the T-scan in no other way. There's no other way that you can do it as well.
Do you think the vertical dimension will influence the sensitivity of the T-scan? When we control the intensity in the bottom, we modified it. We're going to use it with 10, so that we can modify the intensity, the sensitivity of the filter. Do you think the sensitivity will be different by different vertical dimension changes?
Let's augment that question. Not just vertical, but how about the arch size? Like, let's say in a arch that has been artificially made smaller, like in a 4 bicuspid extraction case, or or congenitally missing dentition. Are there things that that would show that we could take notice of?
Well, you'll certainly see things. To answer your question, no, the arch size is only an issue that it fits on the sensor. Whatever the arch is, missing teeth, implants, a crown here, a bunch of fillings on one tooth that's falling apart, it registers the forces there. It's not influenced by arch size. In terms of different verticals, it's also not influenced by different verticals, except if the patient themselves is weakened by the different verticals. So if you want to record them at a vertical that weakens them, then you can turn up the sensitivity, which is essentially the amount of electricity that flows through the sensor. And then their weaker closure can be captured with a little easier sensor response. And if you have someone who's really powerful at a certain vertical, you can turn the sensitivity down and make it a little harder for them to register on the sensor, and you get better data that way. As far as tensing, Dr. Westerson, Curtis and I, we say probably 5-6 years ago, it's got to be now, 2013, 2014, we developed the TENS T-scan technique where you can TENS the patient into the T-scan sensor. And for that, you need higher sensitivities, meaning more electricity running through the sensor in order to compensate for the fact that tensing is a very weak closure. And although it's a very fast closure, that's also one of the things, the beauty of the T-scan, it records in such small time increments that you can actually see a sequence of events in a TENS closure that is 6, 7, 8 contacts. You would never be able to detect that with your eye. You'd never, it's impossible. And it happens so fast. And so there's all kinds of ways to customize the T-scan sensor's level of response to accommodate a variety of different situations that warrant it. For example, implants against implants. You must turn the sensitivity, the electricity in the sensor down to get data that you can work from, because there's no give in the implant system. So they compress the sensor very forcefully with no give. Whereas teeth, they give into the bone, so you can use a little more electricity in the sensor. And then when you have a weak patient who's like a dysfunctional TMJ patient who can't bite down and hold their teeth together because it hurts them, then you can turn the sensitivity up a little to make it easier for them to close. And customizing the sensitivity is one of the great advantages of having the sensor. You can make it fit the patient's scenario extremely well.
I have a question from somebody that's watching, if I can. So the question is about the same missing arch. Is there any opinion that you have? Let's say if somebody's missing a canine, would it be better to replace the canine with an implant or to close it with orthodontics? Do you see any?
So what happens when you put a premolar in a canine space is you now have a posterior tooth creating high muscle firing as a guiding tooth. So that is moving the tooth doesn't change its neuroanatomy. Again, the neurology is at the core of all that we do. So it would be better to distalize the space and place an implant and then use the lateral and the central to be the guiding teeth and exclude the whole side from the lateral, basically the distal to the lateral back, all the way back, including the
Understood.
And so that's, again, thinking neurologically. It's certainly easier to move a premolar into that space in theory than doing surgery to place an implant. But you also then compromise the patient's neurophysiology for the rest of their lives. You set them up to have high muscle firing because the guiding tooth would be one that promotes high muscle firing, and you don't want that. And that's the beauty of the anterior tooth neurophysiology difference from the posterior tooth neurophysiology difference. You have anterior teeth strike, they don't elicit high muscle firing. But posterior teeth, as soon as they touch in any direction, they're firing off muscle activity.
Robert, now that you mentioned that you were talking about the tensing combination with this scan, that I love it a lot, and honestly, I'm willing to learn more because I try and again, I find them fascinated, but also I find them challenges because sometimes the dissolution time with the tensing eventually is giving, I call it the little snake in the middle, right? And then that snake in the middle not always is in the middle as you want. So my question is, how much is the influence for the pulsing? how much is the influence for the muscle balance can be only premature contact. So I'm seeing this for 3 point of view. The first one, because I understand that in a patient that is biting in habitual occlusion, that's what we're checking. Which teeth are touching first? And that it will make the snake to move, right? That's the occlusion timing in habitual. I call it the snake because it's more because you know what? Because many people doesn't even know that that little snake is in the middle. And then everything looks nice with the pistons, but you pay attention to the snake and you say, this is not what I want, right? But then
Yes,
when you do
that's
it with
very
the
true.
tens, yeah, but then with the tens, what I experience is you can affect that snake by the balance in the balance on the bottom of the tent. So you can create more strength in one side that technically that will give you a lateral path in trajectory, but also can be a response of the muscle that the muscle is not rested because again I'm not taking in his own habitual power, I'm inducing it with involuntary thing. So I have three variables in there. What do you think we need to prioritize, or what can be the difference between those three things, those three
Well, that's a
factors?
very good question. I'm not sure I could tell you what the priorities of those three things are, but to direct you appropriately, the trajectory you're talking about, this not the neuromuscular trajectory, the center of force trajectory is the snake that you're talking about.
Mm-hmm.
It can be manipulated into the middle of the arch by using the timing, by adjusting for time, not for force. And this is, again, these are the things that the T-scan does. It. You just, until you are trained as a user, people just don't necessarily understand that. Timing is much more important than force. So if you were to TENS a patient into the T-scan sensor and got this, a bunch of spikes and then played them individually, you would see a repetitive pattern of order. You'd see a green one come up in some area, you'd see a yellow one come up in another area, you'd see a pink one come up in another area, you'd see a blue one. All of those that don't rise evenly, you adjust. And then the next time you TENS them, you'll see there'll only be a few of those. And the one might be green and one might be yellow. There won't be a pink anymore. But there'll still be 2 or 3 of them. And then you adjust those that rose too fast. And then you TENS them again, and you'll see they'll all go up together. So the timing is not only the first one or the most forceful one. It's all of the forces that rise too fast. They're called force outliers. So you can have a canine strike early on in the closure path, and then a premolar behind it strikes, but it rises to pink. And then on the other side of the arch, there's a green that happens on a molar after the premolar rises to pink. And then on the same side of the arch as the pink, there's a yellow that rises. All of those uneven rises, you treat them all. And that's not what people tend to do when they get the T-scan. They look at the pink ones and say, oh, I got to adjust the pink ones. And if you remember, I told you earlier, if you adjust for force, all you do is move the forces around. You have to adjust for time. And then you even everything out. And that includes closure and excursions. So yes, you can get that, as you called it, the snake, the center of force trajectory, right in the middle of the arch of a TENS case by knowing how to adjust the sequence. And that's, again, a learned skill. People don't take the T-scan out of the box and make it work. You have to have training, meaning dentists need training. Offers very nice training, internet-based and also seminar-based. I offer one-on-one in-office training. That's by far the best training because you're doing your own patients with your own staff. You're learning as you treat people. Seminar learning is great because you get concepts and you learn software features and you learn what you should be seeing, but you don't adjust anything. You can't. So, and for your example, a beautiful training for you, Javier, might be you have, a few really nice neuromuscular cases that you really are, want to see what the T-scan would show you. And then we refine them using the T-scan EMG. And then you would see this is how you do it. And then from then on in, you would never go back because once you realize when you put a case in and it looks really beautiful and then you put the T-scan in and it says it's 65-35 and you realize it's good. And you can't hide from that. And what's fascinating about that is it's right in front of the patient. The patient, I was a prosthodontist, I am a prosthodontist. And the patient would say, Dr. Kerstein, why is there a red over there? And it says it's 70-20, right? That's like, right? You can't hide from the numbers. And so what it automatically does is make you better. You realize, oh, 70-20, I can't send the patient home with that. I have to add porcelain to the whole other side. Or maybe I can grind it in and get it closer and then see if I have to add porcelain. There's so much precision that the T-scan offers you. You know whether you did a good job. You know if you didn't do a good job. And that's really where training shows you how to do a good job and what features of the T-scan really matter to be a clinical expert. And I think that's what Ben, if you got Ben on, he would tell you that that training chairside really changed the game.
Yeah, that's what he says. That's what I was about to mention. He say how amazing was that one-to-one. Now I have a question. I'm sorry, it's kind of technical, but honestly, as Hamid and I would say, this is a selfish thing. I was waiting for your training, so I'm asking you everything that I need to know. But I think people can benefit for this because this is related with the Hamid asked about when the teeth are not in the right position or the formula is not complete. I mean, patient is missing one premolar, is missing one molar, and then can be the arch line or whatever. Which strategies are you using to compensate because you're doing this simultaneously with superficial EMGs? So you're checking the response of the masticatory muscles. Which strategies you can do to balance an arch that doesn't have a complete formula? Let's say 4 teeth in one side, 3 teeth in one side, and then you're thinking in the superficial muscles as well. Are you leaving a little bit contact stronger in the side that you have less amount of teeth to try to create a muscle fighting more equal because the lack of support in the side that is less amount of teeth? Is that correctly proposed, Hamid? Is something to correct in the question? You follow me?
Yeah, I think I understand what you're trying to say.
Yes,
It's
if there's
very
uneven numbers of teeth, how do you know if you
correct.
have balance, right?
Yes. So then you put areas bigger or something. How you compensate the lack of that tooth?
Well, there's a very nice software feature where you can divide the arch up into quadrants. And so let's say you have, just to make it visually simple for people to follow without an example, let's say you had canine lateral central on the right side, missing first premolar, and then you had second premolar, molar, molar. Okay, so you're missing one tooth. On the other side, you have canine lateral central, premolar, premolar, molar, molar. Okay,
Mhm.
you can take the canine lateral central area and divide it out from the missing tooth and compare those 3 teeth on the left anterior to the 3 teeth on the right anterior and make them equal to each other. And then you can do the same thing. You can divide the two, you can leave one premolar out of the side that has all the premolars and look at the second premolar back bilaterally and compare those 3 teeth to the other side's 3 teeth, the one that's missing the first premolar. And now you have blocks of teeth that are balanced against each other, and that's how you do it. And so those are the kinds of features that you can divide up the arch. You can, one of the beautiful things we do, which follows that question, let's say you have 2 implants on the left between teeth and the other side, the right, has all natural teeth. We don't want the center of force near the implants. So we actually favor the side away from the implants, and we actually get the center of force to be left of center by adjusting the timing and the forces to control where the center of force goes so that the force summation is away from the implants. And to take that further, if I had 3 implants on the left and 2 implants on the right, I would favor the side that has less implants. I would choose to have the forces where there's more teeth and away from the side that has more implants. And this is, again, the kind of precision that is not matched by any other method that we have available to us. And it's such an advantage to have all these kinds of force and timing parameters and dividing up the arch and being able to flip the arch up and down and import STL files into the software. I mean, it's state-of-the-art occlusion that can't be matched because it measures between the teeth things you just cannot see. Cannot see without it. So that's how we would handle those situations.
That's wonderful.
You know, there's
Now,
a lot of that kind of thing.
So I don't know if the people understand clearly the difference between adjust by force or by timing. Remember, people, the ideal is we have many people that they don't even have the T-scan. So how we can explain this better? We have the pistons that we have 2 different views into the
Yes.
T-scan. So we can see the pistons in 3 dimensions. So we can see where it rises. But also we have the events that happen, the instructions that we gave to the patient by segments, the times of the contraction, the time that you allow to hold that. Can you explain to people the difference between one window of the other one and what you're looking at when you're gonna make your timing and what you don't need to be confused by force.
Well, adjusting by force means picking the highest forces and trying to lessen those. So that would be like you take a T-scan record and you see high force on the second molars on the left, and you adjust it away so that it's no longer traumatizing that second molar. And when you look at the second molar, it has some exposed dentin and it has some recession and it's been getting pounded for a long time. That's adjusting for force. So you're kind of targeting the damaged tooth to relieve pressure on it. And that works very well for an isolated tooth situation. You know, if you have bone loss on one tooth in the middle of the arch and you go and measure it and the person closes down and they've got, 30% of force on that one tooth because it's a crown that was recently installed, that's not good. That's adjusting for force. Adjusting for timing is adjusting either the order of closure contacts as they occur in a recording, how they develop from first to last, and adjusting out all the ones that rise too fast. As I said, the force outliers. And adjusting for timing and excursions is to shorten the diffusion. And these are things I could show you in an example. I could, if you want to share screens, I could try to find something that would illustrate that. I wasn't necessarily prepared to do that, but I can do it. I can show you an example of it.
No, we will leave that for Friday.
For the Friday, yeah.
Friday, okay. Well, Friday, as I said, yeah, I mean, I could show an example of that, adjusting for time.
We just passed the 1 hour marker, Javier. As
Yeah,
promised.
so let's go for the quick. Honestly, I'm in sedation.
It's a
Listen.
much more deeper subject than we can shine a light on in just this 1 hour and a half. That's for sure. Okay, Dr. Kerstein, based on everything you have said, I think you're going to have a completely different view, which is exactly why we want to have this, of what occlusion is. Tell us, what is occlusion to you? And also, just briefly tell us who influenced you along this road.
Well, occlusion for me is a neurologic science. It's not biomechanical, it's not positional, it's neurologic. And the reality of that is how we've been able to study and treat things that dentistry has struggled to find answers for, that we have found answers for by treating the neurology. So and I think dentistry has to come to realize it's a neurologic science as opposed to a biomechanical one or a positionally based one. Because at any position, no matter what the position is chosen, and I'm not arguing about right or wrong positions, the neurology is at play. It doesn't go away because we put someone in a new place, especially when we put the teeth back together. So the neurology overrides everything, and that's what occlusion really is. My influences were, it's interesting, I took a very sort of maverick path, which didn't always go easily because the T-scan showed clearly that some of the concepts being advocated at the time I was a young prosthodontist were not necessarily true. Conceptually, they were being strongly believed, but they weren't necessarily true. And an example of that, a simple one, is big paper marks were forceful. I started using the T-scan in 1984. Every time I marked the teeth, the big paper mark was low force, right? And it took a long time to prove that to be true because, dentists for some reason didn't grasp the idea that pressure is inverse to surface area. And so that's why a lady's high heel, when she steps on your foot, really hurts. But if she steps on your foot with a flat shoe, it doesn't really hurt, right? Well, teeth are the same way. They have points.
Interesting.
Points and cusp tips and marginal ridges that are triangular ridges that are like the bottom of an ice skate, and so there's all these small marks that get made out of the carbon paper, chopped up into little bits that actually are very high force that no one really understands what they mean. So my influence changed because I started using a T-scan in 1984, but my training was in classic occlusion, Schuyler, Dawson, Pankey Mann philosophy. That's what Tufts taught as a prosthodontic resident, with the idea not so much about occlusion, a position being a solution for dysfunction, which is really what some of the battles are, is, what's the right position to treat TMD? It's not the case at all. You can't treat TMD positionally because, again, the neurology overrides that. The idea of using centric relation as a point to be a reconstructive dentist was very prominent in the time that I was learning prosthodontist, and that was using bimanual manipulation or a lucid jig or some kind of a deprogrammer to find that position, and then you would record that and then begin your prosthetic reconstruction on that hinge axis. that concept is, again, using the T-scan has, again, for me, has invalidated that concept, because the idea was that you wanted the joints to be seated, when actually imaging, which also developed at the time I started using the T-scan, shows clearly that when you put the mandible in a strained position bimanually, you're not in the middle of the disc. And MIP, actually, imaging shows that MIP is a better place to put the disc. And so I started working with MIP more, and that became a bone of contention. As I began to write articles, people from the hinge axis camps would say, why do you think, anterior guidance is more important than centric relation? And I said, because people function and they move around, and positions aren't the answer. The teeth have much more going on, and my research clearly proved that. And now others who are doing the same thing, other researchers are seeing the same thing. So positionally, you could argue one is better than the other anatomically, but there's no science behind them, actually. I don't mean to criticize. We've produced so much information that when someone says, well, we should be in this position because, this is our theory, there are no studies with hard metrics supporting the idea of being in an aberrant jaw position outside of MIP. There's concepts around how to treat people that way. And I think the value of those positions is really helpful in people that have skull-based damage and have condylar damage. That's where moving the mandible really helps people. But the average patient who has 28 good teeth and can't chew gum because their jaw gets tired doesn't need a new position. They need their exclusion fixed. And they need to have low muscle firing. And they need to have freedom of movement in and around the central fossa that's timed and highly precise. And then the symptoms go away. So all things that were being advocated to me, the T-scan challenged, and it also created its own sort of barrier to adoption, because I was talking about things that people weren't necessarily happy to hear. And but the beauty of the T-scan is you can use it in any philosophy, and we've also taught every philosophy how to use it. We have applications in neuromuscular dentistry, we have applications in centric relation dentistry, we have applications in splint dentistry, we have applications in implant dentistry, periodontics, orthodontics, even endodontics. A lot of people will get rid of tooth pain by having their bite adjusted, one tooth with the T-scan. So we save pulps, and we save teeth, and we save implants. So I would say, to answer the question, the T-scan has been the biggest influence over where I've gone in occlusion. And no one person has been able to overwrite that because there isn't science behind an unmeasured approach yet that compares to what we've produced with the T-scan.
Fantastic. Okay, so prior to stabilization of your patients, and I'm now thinking about somebody that comes in and they're possibly really ground down, and you're obviously going to see that, yeah, that they probably need some sort of rehabilitative work. What are your stabilizing criteria? What are you looking at? Are you looking at their posture, airway, anything else aside from the occlusion time?
Well, yes, of course. We look at joint health, obviously, with ICT, JVA. We look at teeth and muscles. We look at posture to some degree. I think there are people that are finding that the T-scan applications of posture are growing. And myself as a prosthodontist, I was looking at the patients from two distinct veins. One is dysfunction. What's the simplest way to treat this person who has dysfunction? And then how do I do prosthetic rehabilitation successfully, on this type of patient that needs, rehabilitative dentistry? And the T-scan facilitated both. And so I basically applied my prosthodontic education, but used the T-scan to case finish. So whatever the workup would be for a typical prosthetic patient, full mouth X-ray, mounted study cast, which now would be digitally mounted study cast, but back then it would have been stone models, waxing up, writing out a treatment plan, developing any kind of, using, at that time in the 80s, it would have been a panoramic and maybe a tomogram would have been to check the health status of the joints. But now in the, in the 2000s, it's obviously
now, do you find it more useful now that you just mentioned that in version 10, now the possibility of the STLs? How are you working with that part?
Yes,
that you can see exactly the context.
That's a great advance. That's where you can import, for those of you who don't know the T-scan, you can import the STL file into the software, and you have T-scan data presented to you on the STL file, looking at the occlusal surface. So it's a really tremendous improvement. And you can modify that arch, you can stretch and squash it, you can rotate it, you can get the data to fit exactly onto it, so you know exactly which cusp you're dealing with and that sort of thing. So that's a great advance. But it's important that people realize STL files and scanning technology does not give you forces. It's not, all those orange, blues, and greens are not force. They're geometric progress.
Yeah, it's distance between the two meshes, that's between the two
Right, it's
areas. Only
distances,
distance.
right. But people don't get that because the scanning companies are saying, well, yeah, you have the occlusion, right? Right. It's kind of like you can move the stone models on the articulator. You can mark the stone models with paper, but you still don't have force, right? So you can take the digital scans and you can move them around and you can slide them back and forth. And you can see the patient making excursions, but you can't measure the exclusion time. You can't tell how much force is on a mold that's being shoved laterally while that's going on, right? So the scanning companies are, in their planning software, they are misrepresenting the idea of force. And dentists need to realize that. And planning the cases is great, but it doesn't guarantee that you'll have low forces on the teeth when you deliver them. That's all about soft tissue elements that are missing. That's all about how the temporary did or did not hold the tooth in the right place when you put it on a month ago or a week ago, or if it's in the same day. Once you unload the occlusion by drilling the tooth down, it moves up. Within 14 minutes, it moves up 80% of the time in the socket that it's going to move. So there's fascinating changes that go on that the stone models and the virtual models, they just can't accommodate. And that's why they're a great advance. Scanning is a great advance for the patient because it takes away the gagging, it takes away the impression making, the difficulty of that. But it's no different than taking an impression. It doesn't give you force. You can put the cast together on the articulator, there's no forces in there. So a virtual articulator, there's no forces in there. Dentists need to realize that. There is only one way to get the forces from between the teeth. And that's
I'm gonna make my last question before Hamid jump into that one. I promise I'm gonna be the last one, at least. We're talking about this occlusion time. Let me put it this way. It's still people that question the fact of the thickness of the sensor. And is another company that make another device and they focus in this thinner. I seen both point of view. Some people is thinking in precision. In the long run, when you have to buy the sensor, you still realize that you want a sensor that is not disposable in one use, that you need to change 5 for every patient. So thickness in some part protects. Correct me if I'm wrong. The forces can be diffused because the thickness, but the timing not.
Well, the spread of force on the sensor is greater under greater force because of the thickness. A thinner sensor might show less force spread because it's not as compressed, because it's not as much surface is between the teeth. But the thickness is not an issue that dentists make it out to be. And this is very important. The digital sensor is a printed flexible circuit. If it breaks, you get no data. You get corrupted files and you can't record on patients. And so the T-scan sensor is used all over the world in many different industries. You can bite on it, walk on it, sit on it, drive on it. You can put it on the bottom of racehorses' shoes and watch how fast they run. I mean, it's incredible how many things you can do with the T-scan sensor. And so it holds up to repeated crushing. And the sad part of this question, and not to criticize the question, but the sad part about having to deal with this question for 30 years is people don't realize you're measuring something that you need a specific entity to do. The fact that it has a thickness, it still allows you to read things off teeth. You can't get it any other way.
I think
I just ask because I hear that question. I'm a user. I believe it. It's just that people say, this kind of thing.
We're trying to understand a new subject by the same measuring that, that's still our thinking are going, oh, the thicker paper is going to give us more, wrong data.
Yes, it does.
Talking about the paper itself.
Yes,
that's why we go to a thinner one. I think that's that mentality that they haven't changed that yet, because we're completely looking for different parameters with this. And that's, you know, you had at that point, for me, the first time I saw those bars going up and down, it's the low-hanging fruit. Oh, that's the force is too high. You know, you want to go right there. I never thought about the timing being more important than those, and the balance. But you know, as with any new technology, the thought processes has to be also changed and adapted to that, rather than to try to
Well,
understand it through the same old eyes.
the thickness of the sensor, it's important that people understand that the nature of recording occlusal data without getting destroyed, without breaking, is C-scan does it over and over and over again, which is really great. That's what everybody wants, right? They don't want it to, you know, we are concerned if we use the carbon paper too much that it won't ink up the teeth. We don't think about that. We don't say, oh, the carbon paper has 3 tries, I'm going to get a new one. Right? We don't think the carbon paper has a thickness because we put it on one side, and that throws off the intercuspation on that side, just like a T-scan sensor keeps the teeth apart. But the value of measuring the interface pressures far outweighs that worry about the sensor not letting the teeth actually touch, because of what you can learn from having this sensor between the teeth when it's being crushed, right? It's incredible. That's how we control the neurology. We couldn't do it without the sensor. The other thing to realize is, as you mentioned, the new product, I think it's great there's a digital tool. I think it shows there's need for digital tools in occlusion. People have to realize a thinner sensor doesn't mean anything when the product hasn't been figured out how to use. Digital occlusion is not carbon paper, right? It has to show data that has to be understood. So the OccluSense data is not a T-scan data. You don't even know no one knows what it means. No one knows how to use it to apply it to make a better denture or to adjust someone's bite. No one even knows how to quantify what it's showing. And is it accurate? No one's tested any of those things. So a digital tool is not traditional occlusion. It has to be verified. Is that sensor accurate? Is that sensor going to be able to reproduce force 25 times like the T-scan sensor can and hold up, right? If it can't hold up, and it costs, I think it costs $16 to $20 a sensor. If it breaks after 2 uses, well, that's very expensive. A T-scan sensor is $6. It lasts 25 times. I mean, that's pretty good, right? So you have to weigh the value of the data. In other words, no one knows what OccluSense does. No one knows how it works. No one knows how to record with it. No one knows how to read its data. So what is the value of it? It's unknown. Alternatively, the T-scan, 36 years of research. We know what to do with the T-scan data to make a better denture, to make a better implant case, to control TMD problems with disclusion time. We know how to do these things. So there's much more value there for a doctor considering products. There's also something that just came out, not came out as in literature, but something very important to think about. The T-scan, all components of the T-scan that meet the patient are cleansable, disposable, sterilizable. You can spray the recording handle with Lysol, and you can wipe the supports down with a hand wipe, and you can brush the sensors off with alcohol, no problem. You can cold sterile or hot sterilize the sensor supports. The OccluSense sensor, this is really important, has a cardboard frame. Cardboard, the virus lives on for days and days. You can't use cardboard sensor in the patient's mouth. So this is a huge problem that people don't even grasp it. And here we are, we're indoors doing CE because we're all trapped by the COVID virus, right? So now that sensor is wrapped in cardboard. That's not cleansable. It's not cleansable. So something to consider.
Fantastic. Let's go to question number 3, and we need to move on. What type of, can you tell us about your diagnostic records? A patient comes in and you know, what type of records are you collecting?
Well, we went over it before. We do JVA, joint vibration analysis. Again, if it's specifically classified as an occlusion problem or a TMJ patient, then we're going to do all these things. A JVA to see their joints, what their status is, and if that warrants something further, a CT or an MRI, that would lead us there. T-scan EMG is absolutely essential to verify that the long disclusion is causing high muscle firing. You see it instantaneously, and of course, it just tells you that the person's occlusion is amping up their head muscles and their neck muscles and their throat muscles and their ear muscles. And they may not have symptoms in all of those, but they also may have many symptoms, as I'm sure you've seen people come in. And then I used to make a lot of mounted models. When I was a graduate student, we always made mounted models. That's how we became prosthodontists. We waxed up, we did all that. But as I used the T-scan to diagnose occlusion, I was able to not have to make models as long as the patient had anterior teeth that touched in some way that was reasonably overlapped. Probably 2 to 3 millimeters. If they didn't have anterior contacts, then I might make mounted models to decide, is ortho best, is prosto best, like bonding in contact versus making them move all their teeth. But I got away from making mounted models to diagnose occlusal problems because the T-scan EMG is so powerful and I didn't need the spacer relationships. Now you take a prosthodontic patient, of course we would make mounted models. Now we would make scanned models. We would do a wax up, which maybe now would be a virtual wax up. We'd have x-rays, we might have a joint vibration analysis as well if we were doing prosthodontics, because that's a very helpful screening tool to rule out a bad joint in a patient you're going to do 12 units on or something like that. So that would be my typical protocol. And then if we were doing research, we would add in jaw tracking, possibly a mastication test, which we've done an amazing study on mastication, which shows how really fast the DTR process works, fixing chewing in 7 days. So I might add in mastication, but that would be the basic workup.
That's great.
I'm biting my tongue to ask.
You promise no more.
You can ask. I'm happy to answer.
No, but we cannot abuse the audience as well. They can be in love to hear you, but they don't want to hear the echo of our voices anymore. We've been too long here. They will stay with you forever. They don't want to hear this Spanish.
Doc, let me move on. On the instrumentation that you just used, you said CBCT, MRIs. I know you use a lot of by research equipment. Is that the same as with the jaw tracking?
Yes.
That you use?
BioPack.
Yes.
Okay.
The BioPack has 4 elements: the mastication module, the JVA, the EMG. They have a TENS unit, and then the complete BioPack and also includes the T-scan. And you can purchase them all as individual entities or together. And they all have very important roles. But predominantly, if someone wants to treat occlusal problems effectively, the T-scan EMG is by far the most effective combination, no question.
Fantastic. Yeah, no, it sounds like a great thing. I can't wait to learn it. Let's talk about the interdisciplinary approach. Are you normally doing any of these cases with other professionals?
Well, again, the TMD patients usually are single practitioner treated unless there's going to be a need for alternative adjunctive help, like a physical therapist or a chiropractic care or posture care afterwards. DTR, the reach of the neurology is so powerful that posture improves, mastication improves, tooth sensitivity improves, many ear symptoms improve. So I only used adjunctive therapy when it didn't resolve the case to a point where the patient was living much more comfortably and they needed additional care. So my multidisciplinary approach would really be, is this patient treatable today, or do I need them
But that's
orthodontically?
That's understandable. So at some point, if need be, and you don't get your results, you do work with the PTs and
yes, absolutely. Because there's no 100%. I think the value of the DTR process is it removes a lot of electrical activity in the person's head, and then certain things that don't heal or are different, have a different pathology, need to be addressed. But as a first step, it relieves a lot of things, and therefore people start living comfortably or much more comfortably, and you can isolate what remains and then target with the adjunctive practitioner.
Sounds very reasonable. I think you answered this next question somewhat. The sequence of the treatment, especially with somebody that is vertically challenged. Let's say they're essentially extremely overclosed bites, and you look and say, I'm going to have to open this person up.
Yes.
Can you, and would that be somebody that maybe you would need to see another professional with or not? Can you just give us a brief sequence of treatment?
Yes. Well, if someone has jaw relation problems that warrant intervention before the dentition is addressed, then I would usually refer that person to someone who did orthotic repositioning, and they'd send me back the case with the physician, and then I would prosthodontically put them together. Or if they were the kind of case that I felt should really have ortho, then they would have vertical ortho done, that kind of thing.
Fantastic.
Be prosthodontically put together. But yeah, orthosis was very helpful in obviously many situations where the dentition couldn't be addressed initially, and the dentition wasn't necessarily the primary problem, right? So orthosis really was a great additional avenue to take. But the fascinating thing, and I think Ben alluded to this when he spoke, he said he's making a lot less appliances these days when he spoke. By having the DTR process in your armamentarium, it bypasses the need to put everyone in orthotics as a first phase treatment. And I'm not saying you shouldn't put people in orthotics as a first phase treatment, but many patients who came to see me and who are seeing Ben have a handful of them, and they're not any better, or they're not better enough to, let's say, they're happy, and they don't want another orthotic. They want their neurology fine-tuned. That's how the problems really go away. So I got away from making, preliminary appliances. And then I carried that over into my prosthetic practice, where I would actually open the bite. I would go right to provisionals because the T-scan would allow me to do that. So if I had someone whose teeth were worn and I needed to open them 3 millimeters, I would wax the case up after mounting it, and I would go right to provisionals, use the T-scan to optimize it, and totally bypass the appliance phase. And it worked extremely well, because patients live better with teeth than they do with orthotics. Not all patients. I certainly did use orthotics at times to open someone's bite, but as later years,
I think this answers our question, because possibly we're bunching up a lot of patients, and there are different level of patients, and
yes.
This gives us another tool to maybe categorize our patients, and as a first involved, it's not that invasive as a start with patients to further categorize and see, does this case really does need it? And I think it answers one of the questions that we had. I think Dr. Martin Fraschetti had asked, but I think we are answering it, that in cases where a neuromuscular bite is needed, for instance, in somebody with a skeletal discrepancy, you're still going that way. So this modality is not necessarily exclusive of those cases, but it can actually be used alongside with it, and to give more kind of a neural, bring more of a neural equilibrium, if I can say it, to the body at a different level, at a higher level, possibly.
Well, so just to follow up with what you're saying, so let's say someone is skeletally compromised, needs a neuromuscular bite determination, goes through that process. So their orthotic that they get is adjusted with the T-scan and the EMG too. At the time they would get it, they'd come back. So the doctor would do the orthosis for me. They'd come back, and I would then reevaluate their appliance with the T-scan EMG and fix it up so that it was optimal to make their new vertical adaptation simpler, right?
Easier.
Then they would go through whatever was needed, with regards to the orthosis. And then when we put their teeth together, they would have the T-scan EMG used again. And that isn't just enough to say, we will use the T-scan. No, we would fix the bilateral simultaneity. We would fix the disclusion time. We would put the same parameters into the prosthetic case that we would put into the natural tooth case that didn't need that, because that's how you control the neurology. The high tolerances, as I said, the periodontal ligament doesn't know there's a crown up there. It doesn't think about that, right? It's responding neurologically no matter what's up there. So we would use the same delivery principles in my prosthetic patients that maybe went through a neuromuscular reconstruction that I would use in a natural tooth patient who came in with symptoms and just needed their bite refined, right? And so the
Sounds completely logical. Yes.
Yeah.
How is the? Well, I need to 1 second because honestly I have a sponsor over here. They say abuse him. I'm enjoying this, so I'm gonna take advantage of it. Um, I'm just curious about how is the neurophysiology of a tooth in ortho that you move it. Um, what I'm asking this is because in orthodontics, many times we lead the bite for a timing to saddle the bite, so still some freeway movement to define moment when you finish the orthodontics. And of course, that changed the entire dynamics, what is called the saddling the bite. Is that correct, the term? Yeah, I think it's how we say in English.
Settling, yes.
um, what do you see in these cases? Do you think that the periodontal ligament is in some point immature until it became stable for the new osteoblastos and the new bone matrix? Uh, is anything of this that you have done to understand that we can see what can be the application utilization in T-scan? Let's say to say this patient is done in orthodontics, because I have it in stable, I can move to prosthodontics. Sometimes we do intermediate orthodontics, and then these
Mm-hmm.
patients that they want cosmetics, they want to move. They think that because they finish with the last aligner, you can put the veneer next week, right? And they still, we have this time that we need to. Is there any
Yeah.
ways to use this scan to try to see some values that can tell you maybe it's too much flexibility in the ligament, this bite is not, something like that. You
Well,
follow?
you could only see, that's a very good question also. You couldn't see too much flexibility in the ligament. You could see poor forces on some teeth that would make a tooth more mobile, let's say, than another tooth that had less force on it. And you'd correlate that mobility to the fact that it's receiving a lot of applied pressure that the T-scan isolated for you. So how that would work in terms of settling is you can either use the T-scan to adjust the teeth so they settle with good forces on them. In other words, person comes out of braces or out of aligners, you fix their bite right away so that they have balance and good disclusion and time simultaneity, and then you let them settle, and then you come back to it a few months later when it's been solid. Because osteophytic bone, which is the bone that's labeled the liquid bone, that takes 9 weeks or it's either 9 months, I think, to totally heal. So you'd come back to it a few months later and verify that the teeth are no longer mobile, and then you could refine the bite with the T-scan again to optimize the settling result. Or you could just wait a few months in retainers and then optimize the bite with the T-scan and after settling took place before you did the prosthodontics. And then when you did the prosthodontics, you would use the T-scan again to optimize that end result. So we used the T-scan through the years in orthodontics many times to monitor progress. And this was a really important thing because the orthodontist, they would say, yeah, Mrs. Smith, she's all done. And then I'd have her, okay, come in, Mrs. Smith, let's record you. So make sure your bite is okay. And then we'd record her and she was 65 left, 25 right, like that. It was like 3 teeth were hitting on one side, 2 teeth were hitting up front, no teeth were hitting in the corners. And, it was clear that the case wasn't ready, but the orthodontist thought that they lined up nicely. So the T-scan was a great monitoring tool. So I'd send the patient back with the printout saying, no, the bite really isn't there. Please move these teeth into contact. I'd be specific about what they needed to do. And then the next time they came in a few months later, most of those things would be accomplished. And then I would record them again, right? So the T-scan is very useful in orthodontics as a monitoring tool and then at case finishing. So at any stage you want to, I guess to simplify it for the listeners, any stage you want to have ideal neural control, simple patient adaptation, less occlusal problems to deal with in the middle of a treatment course, using the T-scan helps you do all of that. And it's not about appliances or braces or implants or crown and bridge. It measures all those things for you regardless of what materials are involved or what stage of treatment you're at. So there's always an opportunity to optimize the occlusion. One of the best ones I used the T-scan for as a prosthodontist was provisionals. Now, the last thing you need is that same provisional breaking 7 times, while the patient's waiting to heal from perio, or they have to go through 5 endos. And every time they come back from having it taken off, it's fractured. You use the T-scan at delivery of provisionals, you have a lot less problems with breakage and fracture and dislodgement and having to re-cement. not every case, but many, many cases. I remember some of my patients that I would redo the work. They'd say, do I have to wear a provisional, temporary? And I would say, of course you have to wear a temporary. You need gum surgery, you need root canal. Oh, I had so much trouble with my temporaries. They're always breaking, coming loose. And I said, well, did they use a bike computer on you? Well, what's a bike computer? Oh, well, I'll show it to you. And no, they didn't use that. They just used the carbon paper, right? And of course, then we install the provisional with the T-scan. And then it doesn't come off very often. It doesn't break very often, right? That's a huge advantage in a prosthodontic practice. Multiply that by 10 reconstructions at the same time going on, right? How many extra visits that would save you, right? So there's value for measuring the occlusion at any stage of treatment in any discipline that we're all involved in.
Fantastic. Let's move on with the questions. Doc, we also spoke to another prosthodontist, Dr. McClendon, and he's of, I believe, OBI and facial aesthetic background. Where do you start to consider facial, aesthetic for your treatments? Where does that come in?
Well, in the prosthodontic patient, it might come in right from the beginning. Obviously, it could be a veneer case or a reconstruction that has an aesthetic component, like the front teeth are all sanded away and there's no guidance anymore. All that, excuse me, all that has to be factored in. But in a pain patient, it would be the the last concern. Generally, I would try very hard to, excuse me, work with the dentition as it was. If I couldn't work with it as it was, then I would do ortho to improve the alignment to make it easier to treat. And that would generally be to couple front teeth that were slightly apart or open canine contacts that would require bonding, that there were other occlusal issues, alignment issues that ortho would better serve, right? And so aesthetics would be a concern maybe in those patients, that their front teeth would change alignment and they'd be, put into contact. But the pain patients, I would consider aesthetics to be at the bottom of the curve in terms of what was really important, because they really just wanted to be more comfortable and live without the emotional duress, being depressed, being chronic pain. They wanted to live without the chronic pain. They wanted to live without an appliance. They were tired of wearing an appliance. Excuse me.
You see, we kill you at the end. You see, you say, squeeze me, squeeze you.
Tired, yeah. All right, let's go ahead with question number 8. And this is in reference to your patients that you will see and you find with your JVA and confirm with the MRI or your CT that there is definitive degenerative changes in one or both joints. Have you had any experience or familiarity with the introduction of growth factors into the jaw joint to facilitate the remodeling and healing there?
I myself have no experience with it, but I would imagine if people are trying to do it and they're probably seeing some success, because these natural compounds are readily adapted or absorbed by the body, I would think. And I can't speak specifically for how much that compound helps joints, but I have to believe someone is seeing some improvement with it. And of course, the truth would come out with studies showing the same patient with the damaged condyle getting this material placed in there, and then 3 months later coming out with a normal condyle. And they'd have to do enough cases to show that, but that would be the kind of thing that could easily be researched.
Yes, yes. All right. I think you touched on this, but the question is, do you notice postural changes after treatment, expected, unexpected, positive, or negative?
Specifically with DTR, the posture changes are readily apparent and they don't take long to kick in. So I would expect them in a patient who has, slightly uneven shoulders and holds their neck off to the side a little and, maybe protrudes the mandible. They tend to notice it themselves. And some of their treatment practitioners also notice it. They'll come back for a follow-up appointment. They'll be, my chiropractor was amazed at how aligned my neck was this session. And he always commented how bad it was, for months and months and months. So again, the reach of the fibers into the reticular formation, the tooth, molar pulp and periodontal ligament fibers reaching into the reticular formation has incredible implications for all kinds of things that are going on around the head and neck. Various dystonias that occur, various spasm conditions that occur, various unexplained weird diseases that occur, like Ben is having tremendous success, Dr. Sutter, treating Meniere's disease, which is unilateral hearing loss. And the medical community doesn't have an answer for it. They don't know why it comes, and they have no treatment for it really that's effective. And Ben has done cases where with hearing tests, the person's hearing has returned, 20, 30, 40%. And this is, again, most likely because there's an improvement to the tympanic membrane. There's an improvement to the muscles that control the inner ear. And there's, again, this has to do with the neurology. So there's a lot of things that DTR has had success with. For example, trigeminal neuralgia. DTR often helps trigeminal neuralgia really well. Ben has been studying that as well. And of course, the industry doesn't have an explanation for trigeminal neuralgia, but it's a neurologic event. It's like an electrical short in the mandibular branch of the trigeminal nerve. And it goes away very often after DTR. So the neurology, again, is really at the core of what I would be doing and would be the primary driver of what I would do.
Perfect. This next question has to do with the possibility or availability of this technology as it's taught in schools. Are you currently teaching these ideas and these type of really organic, or I want to say physiologic principles in school or not?
Around the world, there are many universities who use the T-scan and the full biopack, and probably internationally, there's many countries that actually have the information and are learning all of these things. In the United States, there's less of a change in the educational system to adopt measurement with respect to occlusion and occlusal physiology. But at the same time, many schools are running to buy scanners and printers and CAD/CAM. And so the adoption of occlusal technology would be faster if the American universities realized measuring the occlusion is a lot better than basically guessing at the paper marks. Do you guys?
Yeah, that was the second part of the question. When do you think are we going to be ready to accept and incorporate some of these in the United States?
Well, I think it lies in the education system adopting modern principles. Realizing that there's many years of research have been done already, and the resistance to adopting the T-scan is still there because the educators will say things like the sensor's too thick, right? And so an unknowing dentist in the room is like, well, if Dr. Expert doesn't think the sensor's any good, why am I going to, spend the money on a T-scan? When the Dr. Expert doesn't even know what the T-scan does, how it works, what it shows, what value it would bring to his educational continuum and to his students, how much time it would save them in all disciplines. And so the politics is more of a problem, I would say, than the education. If the politics improved with understanding how important measuring the occlusion is, it's carbon paper doesn't measure anything. Wax doesn't measure anything. Silicone doesn't measure anything. People are just looking at holes or ink spots. They're not looking at pressure mapping. They're not looking at timing in fractions of seconds. They're not able to control the neurology in any of those, with any of those indicators. And of course, the patient is the loser, right? The patient goes and spends $10,000, has 5 implants placed and gets this fancy prosthesis, and then they get it installed and it hurts them. And they go back and they bite on it and it gets adjusted, and the dentist grinds where they think they should grind instead of grinding where they know they need to grind. That's the beauty of the T-scan. It says you grind here. This is what needs to be fixed. Not, well, there are 7 dots. I think that one's the right one. Right? That's the essence of why we have so many occlusal problems. People rely on indicators that don't measure what they need to know. So until the education environment adopts measurement for the occlusion, and that also includes measurement for the muscles, measurement for the joints, imaging, it's all.
Once you measure it, it's a fact, correct?
Yes.
Without measuring, it's all a guess.
Yes.
All right. Our last question is Javier's pet peeve about the dynamics and the events happening in the jaw joint, Doc. Now, as a prosthodontist, having studied all these different philosophies over the years, what do you think are the sequence of events happening during opening to the condyle and the meniscus and all that in reference of the rotation or translation or concurrent with it? What do you think is happening?
Well, again, I'm haven't done condylar tracking to tell you I know exactly, but what I've seen is, and what I've learned is that the lateral pterygoid, being one of the muscles that receives input from the teeth, direct input from the teeth, by it being hypercontracted, it pulls the disc out of place over time, and then the condyle traps it in a bad space against the skull, and that's how you get disc displacement. It doesn't occur just by itself. So the lateral pterygoid is fixed at the temporal bone or the sphenoid bone. I have to figure that one out, which one it is. So it can't move there. But when it gets tight, it shortens and pulls the disc forward because the disc is a movable entity and it's not bound down. So you get shortening of the lateral pterygoid from the dentition, tightening everything up, that it does tighten up.
You're talking about the superior head, because the inferior head holding the condyle, correct?
Yes. So the superior head would tighten up, and then it pulls the disc forward, and then the condyle traps it, and then that progresses as the lateral pterygoid gets worse, and the condyle also worsens it by banging into it in the wrong place. It's now out of place, and now it's getting pushed and shoved into this new space that doesn't belong in. And then once it gets pushed out enough, then the bones start to rub each other. Now you get coartication issues with the condyle, or skull base changes, right? So that's what's really going on. That's where the pathology comes from. It's
but
not,
no, in a healthy, let's imagine a healthy condyle meniscus joint position. And, you know, for many years, there's been this theory that, first there's rotation and then there's translation. First, I mean, I've heard all kinds of numbers, 10 millimeters, 14 millimeters, 20 millimeters. Do you think that there's actually a hinge axis rotation in the jaw joint?
no. The jaw joint is designed to allow for a range of motion that is like an ellipse. It's not rotational. And that's why we have a CRCO discrepancy. Everybody has one. We're not supposed to have them be equal. You're supposed to be able to go back a little and go forward a little and go sideways a little, and go down a little, go up a little. So we have this zone where we can talk and chew and eat and swallow, where the disc stays on top of the condyle. It isn't a hinge axis. And making it a hinge axis has been a detriment to the patient. Trying to a hinge axis scenario is it's not physiologic because of the movement capabilities of the temporomandibular joint specifically. You know, other joints where there's no transitory component have a rotational component to some degree. You can only, you know, move your shoulder so far until it hurts you, right? But that's all rotation. It doesn't displace, right? If it does displace, you need help to get back in there.
Yeah.
Right? Mandibular joint, you can move forward some, you can move back some, you can rotate left, you can rotate right. So we have this zone in there that allows for a series of positions that are all in their own way useful. And we have chewing, eating, and swallowing around those condylar positions in their own way. They dictate to their own degree what's possible, along with the teeth. So
fantastic. I think you answered our questions. Yes, sir.
You passed the test. Congratulations.
Oh,
Amazing.
Thank you so much. And now we're just 10 minutes short of 2 hours, Javier. I hope you know.
Oh my God. Yeah, I'm happy because honestly, this was really unexpected but necessary. I think because Ben just put a little bit of this in us. It's beautiful, but be able to see who's been too many years involved with this is just fantastic, because you see how the progress of the thinking and the technology following all this progression is magnificent. So Robert, thank you so much. You've been amazing. You've been so kind to accept this last minute. we're really excited about Friday to see your lecture and the other ones.
Yes, it's quite a day of lectures. That's pretty unbelievable.
It's a marathon.
Yes.
It's gonna be amazing. We motivated. We don't know. Actually, we don't even know how we were able to make this in the first place because has been 8 days. I mean that we've been live, but
Yes.
many other days and nights of work and thank you guys. I mean all the guests that supported this dream, all the attendees, the audience that is following this. We hope
Yes.
just to take the best for it, and I think
Yes, Doc, it's really was enlightening. Thank you so much for sharing with us all these years of research. You really are somebody that exactly exemplifies what we're looking for, people with critical thinking that go towards what makes sense to them rather than what we see most often is people who decide what they want to accept, and they just look for other things to justify it. And what we want is to get more people like you, really, because we feel we're that way. We do things and experiment with things all the time that makes sense to us, and if something doesn't make sense to us, we're like, wow, we got to move on, find something that goes. So this really makes a lot of sense to us. We're all about measurements and documentation, and I know both of us are really eager to learn this technology for us. And
yes,
so,
this is
Well,
awesome.
I thank you both for the chance to talk, and for, as I said at the beginning, it's quite a lineup of experts you've had, and a lot of work for both of you. And but your interest is very high, and here I am, one of the last ones to speak. I think there's one more question and answer session tonight. You guys, like I'm the first guy, and
Yeah, that's right. That was awesome.
so
Okay, so
thank you.
thank you so much. So for everybody out there, so